Yes.
Just in relation to one point that arose earlier this afternoon, in your evidence, you indicated that you thought that the Barts Hospital Transfusion Committee was started in about the mid to late 1980s. In your statement, you suggest it was the early 1990s, but that the guidelines produced by Alan Waters were produced in October 1985. Can you give us any steer on whether it was the late 80s or the early 90s, or are you just not sure at this stage?
I'm not sure, but I'd be surprised. I think we must have initiated the Transfusion Committee at Barts in the mid-80s. And
again, just for the transcript, the guidelines written by Alan Waters is WITN 7001-004. I want to just look at some very specific topics. First of all, the National Blood Transfusion Committee. If we could turn to WITN 7001-026, please, and page 2. These are the terms of reference for the National Blood Transfusion Committee, and we can see remit. The overall objective is to promote good transfusion practice by providing a framework to channel information and advice to hospitals and blood services on best practice and performance monitoring, with the aims of improving the safety of blood transfusion practice, improving the appropriateness of clinical blood transfusion, exploring and facilitating the implementation of methods to reduce the need for allogenic blood transfusion, listening to and informing patient concerns about blood transfusion, promoting the highest quality and consistency in transfusion practice. 2.1.2, consulting with national groups, developing guidelines in transfusion medicine in order to determine best practice, review the performance of the services provided by the National Blood Service, identify service development needs and provide assistance as required, identify and respond to patients' perceptions about the provision of transfusion services, and providing advice to the CMO on transfusion practice. We'll just leave that up for a moment. You produced an article in 2017 that reflected on the role of the National Blood Transfusion Committee, and in that article you said it was difficult to document the value of the committee with any certainty, but that you considered that the improvements in transfusion safety in hospitals and the marked reduction in blood use across a large country would almost certainly not have happened to the same extent without it. Is there any reason you can think of as to why a National Blood Transfusion Committee with these objectives, with this remit, couldn't have been established earlier?
It could have been established earlier. The two main drivers for establishing it were the Better Blood Transfusion Initiative itself and the reorganisation of the National Blood Service. So those two things came together and led to the National Blood Transfusion Committee. It also came about in relation to the reorganisation of the blood services. The initial suggestions about doing that were not greeted with huge enthusiasm in hospitals, and Professor Gordon Smith, who was the president of the British Society of Haematology at that time, worked with the blood service to develop, and others, to develop user groups, national user groups and zonal user groups to oversee the change of the blood service and to flag concerns that hospitals had about the new blood services. As I say, hospitals had real concern, had some significant concerns about how the reorganisation of the blood service should go, and those user groups performed a useful role, I think, in allowing senior clinicians and senior representatives of the blood services to talk together and overcome some of the misconceptions and issues as the blood services were changing. And And that led to increased confidence amongst the hospitals and to a more collaborative approach to recognising that working together, the blood services and hospitals could aim to promote better blood transfusion practice. And that coming together with the Better Blood Transfusion Initiative led to the National Blood Transfusion Committee and disbandment of the user groups.
I want to move on to issues of information and consent in relation to patients receiving transfusions. Could we turn to BSHA 5011_020? These are a set of minutes of a meeting of the British Committee for Standards in Haematology on the 26th of January 1994, of which you were the secretary. And if we turn to page 4, please, we see under the heading Blood Transfusion, Progress on Guidelines, and we see a paragraph on consent. Consent for blood transfusion. A draft will be discussed at the next task force meeting. The chairman of the task force asked the secretary to circulate the risks and uses of donated blood to BCSH members as a possible basis for an information leaflet to patients. Dr. Regiman indicated that he would draw the attention of colleagues in the Department of Health interested in the question of consent to the draft guidelines, the draft guidelines. Do you recall what was happening in relation to the involvement of the Department of Health in relation to these guidelines at this time?
I can remember at a succession of committee meetings, the issue of guidelines about consent to transfusion were discussed, and the reasons that I find difficult to understand now, there was a reluctance to proceed with such guidelines.
We're going to come to minutes dealing with that.
Oh,
What
okay.
I'm just asking you at this stage is, what was the involvement of the Department of Health in the issue at this stage?
So the Department of Health had a representative at these committee meetings. This was a meeting of the British Committee for Standards in Haematology.
It was, yes.
So the Department of Health often attended meetings of the British Committee for Standards in Haematology, and some of the task force meetings indeed.
Then if we turn to the meeting of the task force in the July of 1994, DHSC 304486_097. We can see that you sent your apologies to this meeting, but would you have received the minutes for it?
I'm sure I would have done in advance of the next meeting.
And we can see at the bottom of the page, consent for transfusion, and the task force had discussed the proposal at length. If we turn over the page, it deals with the conclusions that were reached. The risks associated with blood transfusion were not of such magnitude that there should be a legal requirement for informed consent to transfusion. There is a clear ethical duty upon doctors to inform patient what is to be done to them, and this includes blood transfusion. And then the problem of transfusion given to patients under anaesthesia was discussed. And then there's further discussion about the information leaflet was considered to be valuable, but that the members of the task force felt that this was not an area where they could publish a guideline. Do you recall if at this stage whether you agreed with that decision of the task force or not?
Yeah, again, it's difficult to remember precisely what I thought, but I think I would have found it difficult to agree with what happened, that the guideline didn't continue, because I would have felt that guidance was needed, that patients were not receiving the information about blood transfusion that they should have been receiving. And we may come to it later, but not too much later than this. I think in 96, before I left Barts, I commissioned 2 of the medical students that were assigned to me to conduct an audit of what patients were receiving in terms of information, and whether they felt that they were receiving enough information about blood transfusion.
And in fact, around this time, we looked at the very beginning of our session this afternoon, the Barts guidance, which did say patient consent
Yes.
should be given.
Yes,
So
so that's consistent with what I'm just saying now, that I was struggling to agree with what happened in the British committee.
Could we have the document back on screen, please, Sally? Do you need the reference? No. Can you help us with what your colleagues were thinking about the difference between an ethical duty to inform, but there not being a duty to obtain consent?
I'm still struggling to understand that, what the concern really was. There were, as you know, there were further discussions about this, and the discussions went to the Joint Committee on Haematology of the Royal College of Physicians and Royal College of Pathologists, and decision as a very senior committee, and a decision there was not to proceed with the guideline on consent to transfusion, following feedback from the profession and legal opinion, and that was. We published that in the report of the audit that we did at Barts on consent. I tried to find where that quote came from. I think it was published in the Royal College of Pathologists Bulletin. I've asked the Royal College of Pathologists for that document, but I haven't been able to obtain it.
And when you're talking about the study that you... in fact, no, sorry, let me come back to that in just a moment. Sorry. If we then just follow through the minutes of the British Committee for Standards, can we pick up BSHA 5011_018, please? It's a meeting of October 1994, and if we turn to page 3, we see this at the bottom of the page. After discussions and consultations over the draft document, the task force had concluded that it was not able to publish a guideline. The task force considered there's an ethical duty for doctors to inform patients about blood transfusion. An information leaflet for patients about blood transfusion produced during the drafting of the guideline document was considered to be valuable and will be published in the Transfusion Handbook. The committee was disappointed that it hadn't been possible to take this matter forward, and the Department of Health will inform the task force whether work on this project should be resumed. Again, can you help us in relation to what the role of the Department of Health was in this regard?
As I said earlier, the Department of Health had a representative that attended meetings, and their role probably wasn't completely clear to me, but I think the idea was to have a channel of communication between the Department of Health and the Standards Committee, and in that way try to proceed with initiatives of interest to both, and get support from the Department of Health for the work of the Standards Committee.
But why would it be the Department of Health who would tell the task force whether the project should be resumed?
I presume it was. I'm not sure why that would be. Maybe it was in terms of trying to identify the priority that Department of Health might give to this project.
So when a decision was to be made by a professional body as to whether a guideline was needed, the Department of Health had some significant influence over that.
Well, I'm not sure whatever happened. When I was reading the documents to prepare my statement, I could not find what happened after this note, what feedback was ever received, if any, from the Department of Health.
And the inquiry team to date hasn't identified anything specific on that point.
What is curious to me, if we go back to the DHSC 4486_097,
it is DHSC 304486_097.
Thank you. And over to the second page, it's really paragraph 3. The Committee on Standards, which presumably is to set the standards?
Yes, it was to set guidelines, to write guidelines for haematology.
It ducks the issue halfway through. The question of incorporating consent for transfusion into the consent for operation in some way was felt to be a problem which this task force could not address, and which referred to good medical practice in surgical specialties, which should be addressed through either the respective royal colleges or perhaps by the Department of Health. So that's at that stage. That explains your recollection that the royal colleges then started to look at this. But your recollection is that they said, in the light of feedback from the profession and legal advice. So presumably that legal advice ought to exist in writing somewhere. And I'd be interested to know really what the legal advice was, which provided that it could be good or appropriate medical practice to act unethically. Since the declaration here is, and consistently has been, it's ethical to tell, it's an ethical requirement to tell people. But there we are. That's my, I share what is plainly your puzzlement and Council's puzzlement about quite what was going on. It may simply be that the task force felt, well, transfusions, we just have to really duck this and leave it to the royal colleges.
I find it difficult to remember. I was a junior member of this committee then.
Well, you weren't at this meeting, so... And
I wasn't at this meeting, and it was difficult to understand why we couldn't proceed with the document. And then subsequently, of course, we did make progress, and I've developed a time to help me. I prepared a timeline of what subsequently happened in terms of various other guidelines which indicated that patients should be informed about blood transfusion, that consent should be obtained, and it should be documented.
Yes. I mean, is there a risk that if each individual specialty has its own guidelines, some of which say take consent, some of which say you don't need to, that the individual practitioner, at whatever level, a lot of them will be junior doctors, wouldn't quite know what they should be doing, and certainly wouldn't get into a habit of doing it? Is that a risk?
Yes, no, certainly the case. And one of the issues that we have in practice is actually getting the guidelines to the junior doctors, the nurses, who are those who are actually delivering transfusion practice in hospitals. It's not the consultants who are ordering blood. It's not the senior nurses who are checking that it's the right blood for the right patient. It's the junior nurses and the junior doctors. And getting guidance about good practice to them is really difficult.
Yes.
And maybe we're going to come on to it later. That's why we've explored a different way of supporting those nurses and junior doctors to deliver good practice in a different way, other than trying to get them to read and understand and implement guidelines.
Yes. So we do have a set of minutes from the Royal College of Pathologists. I'm just trying to turn up the reference for you. I don't think we necessarily have them available to display. They are from 1994 and into 1995. The references run from, sorry sir, RCPA 5019 and then underscore 012 016 018 020. And I imagine that some of the intermediate 019s may also relate to it, but they certainly pick up the question of consent from patients. And we don't as yet, but I will ask the team to look again for the legal opinion. What is said in the meeting of June 1994 in the Royal College of Pathologists is simply following feedback from the profession and also taking into account legal opinion, which was largely against asking for formal informed consent for blood transfusion. It had been decided that the proposal paper would be redrafted, and then in the later minutes it's not pursued.
That was June.
June 1994.
Because the meeting of the task force, which we've just been looking at, is July 94, isn't it?
It is, and then it comes back to the Royal College of Pathologists, because in June 94 the paper is to be redrafted.
I see.
And then subsequent minutes effectively shelve the issue.
Right. So that decision in June 94 isn't referred to in the as far as we can see in the
No.
committee's minutes at any rate. Yes. Yeah, curious. Thanks.
What did come out of that, though, was the drafting of a section on providing information to patients in the Handbook of Transfusion in 1995. So we did start to make progress then on having guidance about providing patients with information about blood transfusion and obtaining consent in a national guideline document in 1995. And
we saw that flagged up in the October 94 minutes, where it was referred to being put into the Transfusion Handbook.
Yes, that's right.
Sorry, sir. Sorry, sir, if I can just take a moment to go back. There we go. And the first formal requirement for patient consent for blood transfusion didn't come until 2011 from SABTO. Is that right?
Yes. Yes, for formal consent, as well as providing patient information.
And that was in the meeting of the Advisory Committee on the Safety of Blood, Tissues and Organs on the 10th of October 2011.
Yes.
For the transcript, it's RLIT 40916. And that refers to a paper which we will go to, ASPT 40170. Patient consent, sorry.
Yes, well, in the meanwhile, one of the documents we discussed earlier on, the second of the Better Blood Transfusion documents,
Yes.
there was a section in that pointing out the need to provide better information to patients.
Indeed, but in terms of consent,
Yes.
that
Yes.
wasn't even in that circular.
No.
It didn't arrive till 2011.
No, that's correct.
So we see in this 2011 document in relation to consent on page 3, the recommendation valid consent for blood transfusion should be obtained and documented in the patient's clinical record by the healthcare professional. And the third recommendation here, there should be a standardised information resource for clinicians indicating the key issues to be discussed by the healthcare professional when obtaining valid consent from a patient for a blood transfusion. And if we can turn to page 5, we see the background to this. It's a general legal and ethical principle that valid consent should be obtained from a patient before they are treated. And then it goes through some GMC guidance. And then audits presented to SABTO have identified that the practice of obtaining any form of valid consent for blood transfusion is highly variable in the UK. The following issues have been identified by SABTO. Patients are not always given information on the risks, benefits and alternatives to transfusion or the right to refuse transfusion. Patients are not always made aware that they've received a transfusion. Patients who are unaware that they've received a transfusion may go on to donate blood when they should not, and there is inconsistent practice across the UK. SABTO reviewed their guidance subsequently, and in 2021 you wrote in the journal Clinical Medicine highlighting that review and effectively re-emphasising the guideline by SABTO. So would it be fair that even in 2021 consent for blood transfusion is still not universal?
Yes, and you showed the information from the recent audit, which showed that, from memory, 36% of patients receive no verbal or written information about blood transfusion.
And so would it be fair that if they've not received any verbal or written information about the transfusion, it's unlikely that they've also provided informed consent?
Yes.
And in terms of the provision of information, in your statement you say that in December 2021 you were told that NHSBT had provided 19,150 hard copy leaflets to hospitals, and there'd been 2,269 downloads of it, but that NHSBT had issued 1,286,287 units of red cells, 145,101 units of FFP, and 230,792 units of platelets.
That's right. So
from those figures, what do you draw?
Well, the national resource for providing information on transfusion to patients is not being delivered to them. Some hospitals have their own information leaflets, but I suspect I think the majority do not, and I still think it's the case that most patients are not receiving written information about blood transfusion.
Moving on from information and consent, in your statement you talk about the steps that need to be taken to minimise transfusion errors.
Yeah.
And in your statement you indicate that the hospital transfusion process involves many steps, many different staff, indeed almost all doctors and nurses in hospitals, and is carried out in many clinical areas in hospitals. It's prone to errors which may cause morbidity and rarely mortality. You say, I recognised from my experience both at Barts and in Oxford that the development and publication of guidelines, efforts to improve education and training, follow-up of errors and general exhortations to do better had been insufficient to improve practice and prevent errors. Because of that, you go on to talk about an approach that you've worked with the Oxford team to develop of using electronic systems to prompt clinicians. Can you tell us what that has involved?
Yes, so the initial driver was to focus on better basic blood transfusion practice for the safety of patients to avoid wrong blood transfusions. So the idea was to use electronic systems, so a barcode on a printed wristband for patients with their surname, first name, date of birth, hospital number, gender on it, and a barcode with that information, which could be scanned to check that the barcode on the patient matched the barcode of patient's identification details on the unit of blood to be transfused. And the handheld could also be used to print labels for samples. So when the blood sample is being collected for compatibility testing in the blood transfusion laboratory, the sample could be labeled with a label essentially printed from the details on the wristband. So errors in the transfusion process resulting in wrong transfusion can occur at every step in the process, from wrong sample identification, wrong patient identification, the time the sample is taken, wrong sample labeling, wrong testing in the laboratory, wrong collection of blood, and wrong administration at the bedside. So errors all the way through the process.
What effect has that system had, or is it hoped to have, on the appropriate use of blood?
Yeah, so the process that I've just described to you rather badly is a process that's designed to ensure that patients get the right blood. It's not designed to ensure that the use of blood is right or is as good as possible. So to do that, we needed to provide another electronic process to help doctors at the point that they're ordering blood make a good decision. And that we had to do that, we had to wait until the Oxford hospitals had the electronic patient record system, so that the doctor can look up the patient record when they're thinking about ordering blood and be taken through a stepwise process. And for a top-up transfusion, they can, as part of the process, they're told what the patient's blood count is. So they're ordering a red cell transfusion for a patient that's having a top-up transfusion in hematology or for a medical reason. They're told what the hemoglobin level is. And if the hemoglobin level is too high, according to it's over 70, they get an alert to say, this is outside the hospital guidelines. Do you want to reconsider or not? And they get the option to cancel the order or continue. If they continue, the laboratory will be able to identify that and further challenge the doctor through one of the junior hematologists. And what we also do is to review all those transfusions the next day. We get a download of the transfusions that have been given that have had an alert, and we can contact the doctor to discuss that with them.
And has that system rolled out nationally, or is it still an Oxford-based system?
Yeah, so neither of those processes has rolled out nationally. We've written multiple publications, included the process in multiple national documents, and it is rolling out to some extent. The electronic safety process. The electronic blood ordering process for good use of blood is probably less common, but hopefully as more hospitals develop electronic patient records, they will implement the electronic process for blood transfusion. But it's not widespread. Again, it comes down to some of the issues that we were talking about this morning in terms of leadership, resources, and in relation to IT, the IT capability of hospitals to develop these transfusion processes within their electronic systems in hospitals.
And on that note, in your statement, when you were asked the question about whether in seeking to minimise transfusion errors you'd met with resistance from the profession or other obstacles, you've indicated that the challenges involved, but you've also said efforts to further improve transfusion safety may not be prioritised in hospitals or be thought worthy of a major initiative by the NHSBT or the Department of Health because of the generally perceived low level of transfusion errors and adverse events. When you were speaking of that, are you referring there to current practice or also to an extent a reflection on past practice?
To both, to past and current. It's getting better, but it's frustratingly slow, I think.
We looked earlier today at the 2021 National Comparative Audit. In your view, what still needs to be done to improve transfusion practice?
I think it needs to be prioritised at a higher level. Hospitals have a lot of competing priorities. Obviously during COVID there have been lots of problems for hospitals to deal with. The transfusion is not prioritised at a high level at present because, as I've said, the risk is thought to be low, and there are many other issues to be dealt with.
Are there specific initiatives and steps that you think should be being taken to improve transfusion safety?
Well, we've demonstrated that use of the electronic systems reduces the risk of errors. It's challenging for hospitals to implement those for the reasons that I've given. There's certainly an upfront cost, and there's training of staff to do it, and we need to provide greater evidence, I think, or this is what I'm told, that greater evidence is needed of the clinical benefits and the health economic benefits as well. But there's quite a lot of evidence there that these systems are effective in improving practice, both in terms of the safety of the transfusion process and in better use of blood. But the rollout throughout the NHS has been frustratingly slow.
And you've worked in a hospital context and also in a more of a national leadership role. Whose responsibility do you see it as to ensure that initiatives are taken to improve transfusion safety?
I think this is a really, really hard question to answer. I think it would be really helpful to have an answer, to know whose responsibility it is at national level to drive this, because at the moment I don't think it's clear. In the most recent iteration of Better Blood Transfusion, a document called Transfusion 2024, which leads on from all the Better Blood Transfusion documents before, it provides a higher level of advice about good transfusion practice for the NHS. But the recommendations fall to many different groups, to the National Transfusion Committee, to NHSBT, to the Royal Colleges, to specialist societies, to the CQC, to MHRA, but it's not clear who is overseeing the implementation of measures to improve transfusion practice. So in answer to your question, I don't know. maybe somebody else could give you an answer, but I think it would be really good to know who is overseeing a drive to really improve transfusion practice.
So those are the questions I have for Professor Murphy. I'm conscious that there are likely to be some questions from the recognised legal representatives, and I wonder if we could take a short break for me to receive those.
Yes, well, we'll do that. How long do you think you might need?
15 minutes. There's been a few more than...
Okay. Well, let's then say 10 to 5, shall we? Not before 10 to 5.
Thank you, sir.